Okay, we're back for part 2 of chapter 17, and we are talking about rheumatoid arthritis. And so some signs and symptoms of RA is peripheral symmetrical inflammation of numerous joints, but both on the same side, and both sides, and typically the morning stiffness for greater than 1 hour. Joints affected typically are the knees, your proximal, interophalangeal, and your metacarpal phalophalangeal joints in the hands and the feet. Other affected joints can have pain when they are touched. You may find that they are swollen and partially immobile, and eventually the joints appear increasingly deformed and very rigid and not as functional as they used to be. Here we have 2 pictures. Our photo at the top is someone's hand, and you can see how the joints in the wrist and in the knuckles have become enlarged, how the fingers have crossed, and then you can see these same changes over here in the x-ray part of that hand. And here is just a drawing of rheumatoid arthritis, and here we have a normal healthy joint, and you can see the cartilage. It's very smooth where it shapes that it's covered, and then down here is the meniscus. In a rheumatoid arthritis joint, we have unevenness of the bone where it has been eroded away. The synovial fluid that's around it is swollen and can be irritated. The cartilage has worn down, and we get that more what people refer to as bone on bone, but you can see in both these areas that the cartilage has worn away. And then also we have a distinct difference in joint space because that meniscus has worn its way down as well. So to diagnose RA, we need to check for a rheumatoid factor, and part of that is an IgM response that reacts during an autoimmune reaction. We also will check an ESR, which is your erythrocyte sedimentation rate, or you could check for a CRP, a C-reactive protein, and these are going to tell us more about inflammation. We'd want to check a CBC to rule out anemia, check platelets in that, and then you may also do some joint fluid analysis. For the management of RA patients, it progresses from being conservative when first diagnosed based on the symptoms that the patient has to more aggressive symptom management. The goals are to reduce pain and inflammation, and especially to preserve joint function for as long as possible. Early management includes physical and occupational therapies, the use of heat and cold, exercise, rest, assistive devices when needed, splints, meditation, chiropractic adjustments, and weight loss. And then at the bottom of this screen is some treatment guidelines for rheumatology. In the chronic management of it, medication-wise, we could use some analgesics, NSAIDs, some steroids, and then some biologicals. And if you look on page 967, it includes a list of those medications that could be used in the treatment of RA. So we have a case study. We have a history of a 20-year-old female who experiences fatigue, anxiety, and palpitations. She recently gave birth to her first child, and she begins to see MD number 1, who believes that her symptoms are related to stress and after giving birth and also caring for her toddler child. This doctor has encouraged her to rest. So the symptoms worsen, and then they get better, and 2 years later she develops some abdominal pain, and she presents to another physician who sends her to an internist approximately 50 miles away and says that based on her age and her symptoms, he feels that it's her gallbladder, and tells her that she needs to eat a low-fat diet and practice a healthier lifestyle. And she's also a mom of 2 little ones. 5 years after her symptoms initially began, she becomes pregnant again with her 3rd child. And with this pregnancy, she has some issues with premature contractions. She has fatigue, headaches, swelling to the legs. She has to take a leave of absence from her job because she doesn't have the energy to do what she needs to do along with the premature contractions. But after her bed rest has helped her to achieve full-term pregnancy, and she delivers a new baby. After the birth of that 3rd child, though, some new symptoms come into play, and those include swelling to the ankles, the knees, joint pain to the ankles, knees, elbows, wrists, fingers. She has difficulty climbing steps or dancing, which is something she previously enjoyed. She's having to use more rest and over-the-counter medications to help relieve her symptoms. So at this time also winter comes, and she's showing that she's not tolerating the cold as well as she has in the past. Her hands and feet change colors when exposed to the cold. Her extremities are painful and stiff. She sees her doctor again, and they send her to see a rheumatologist. And he doesn't feel that he can definitively say that she has lupus, so he prescribes some naproxen for her to help with the joint pain. The summer after this, so we're going on for at least probably 6 years now, 7 years after diagnosis, she develops a red raised rash that itches after being in the sun. She develops small raised sores to her legs and her arms, and her joints develop swelling, pain, and the fatigue continues. So her labs are as shown here. We have an ANA that's normal. Her anti-DNA antibody test is elevated. She has a decreased C3 level. Her red blood cells are a little bit below normal. Her hemoglobin is at 10.5, which is the normal for women, anywhere from 12 to 16. Her hematocrit's at 35. Her white blood cells are at 6,000, and her platelets are at 138,000. Okay. What she finds out, though, is that she has been diagnosed with lupus, and it took that many years, approximately 7 years, for someone to be able to put all the pieces of the puzzle together. And I show you that scenario for that patient because lupus is something that is very difficult at times to diagnose. You have to have at least 4 of 11 criteria in the absence of drugs or other disorders to lead to that diagnosis. And so that includes arthritis, non-erosive and usually involving at least 2 joints, photosensitivity that can trigger some skin rashes when you're exposed to the sun, some oral or nasal ulcers, malar rash, butterfly formation across the cheeks and the nasal bridge. You can also have a discoid rash, raised red patches. You can have some serositis, inflammation of the pleura or the pericardia, renal disease, where you are showing some proteinuria, and you may see 3+ or more proteinuria in the urine and some cellular cast. And hematologically, you can also see some hemolytic anemia, some leukopenia, where the white count is abnormal, and lymphocytes can be abnormal, and also low platelets. You can see neurological disease where you're having seizures or psychosis that are not otherwise explained. You can have positive ANAs. You can also see some immunological abnormalities. You can have a positive antiphospholipid antibodies, an anti-double-stranded native DNA. So there's other immunological studies that you may see evident in making this diagnosis. The signs and symptoms of lupus include malaise, fever, anorexia, unplanned weight loss, blurred vision, swelling of the conjunctiva, sleeplessness and depression, swollen painful joints, shortness of breath, painful inspiration, vague abdominal pains, and or some abdominal cramping. We often associate skin findings with lupus, and in particular that malar butterfly rash. We can also see some alopecia and scalp issues, splinter hemorrhages, some issues with some periungual redness and lesions of the fingertips and the toes, swelling, lymphadenopathy in the lymph system. Scarring and highly inflammatory lesions are noticed that form a discoid area, and then also you can have Raynaud's phenomena, that discoloration of the fingertips and the toes when exposed to changes in cold temperatures. So here's some pictures of some skin findings, and you can see on the top we have the redness of that butterfly rash, but down here on the second picture you can see it's a much more raised, rough textured type of rash. These are some nail findings that you can see with lupus. We also can see some musculoskeletal findings. You can have swollen joints. We can have pain in those joints. It may be asymmetrical. It may not be non-deforming, but you can have arthritis in the hands and fingers, and it usually occurs in 90% of cases and is often one of the chief presenting complaints. And you can see how the joint. The next section that we have is on HIV. I'm just going to let you review those slides. If you had someone coming in that you were doing an initial workup that had concerns for HIV, once you received those tests that support diagnosis, then that person would likely need to be referred to an infectious disease doctor. So review those slides at your convenience, and I think that they'll be informative on basic knowledge that you need for practice and for the test. And that will end chapter 17, and we will work on our next video soon. Thank you.